Hello and welcome to the Edwards TNT session at PCR Valves eCourse 2020. My name is Wolfgang Rottbauer. I'm from Ulm University, Germany. The title of the session I'm sharing today is Advancing Tricuspid Repair with the PASCAL Repair System platform. Heart valve disease is a very important topic, even or especially during the COVID-19 pandemic. Some of you might have seen the presentation of COVID-19 valve registry at this year's TCT by Danny Dwyer. They followed up on about 150 patients with COVID-19 positive patients with valve disease. As you can see here, 74 patients suffered from severe aortic stenosis, 28 were affected with COVID and had severe mitral regurg, and 14 of the patients had severe tricuspid regurgitation. As you can see here, now we are focusing on the AV valve disease population. Basically, none of the patients, while being infected with COVID-19, was either treated surgically or interventionally on the valve disease while having COVID-19 disease. So the question was now, what is the effect on the mortality of these patients if they have two diseases at the same time? And I think the information, even when you look at 30-day mortality, is quite dramatic. Over 50% of the patients that suffered from severe mitral regurg died within 30 days of follow-up. So, especially in this context, I'm happy that Edwards Lifesciences put together this session on advancing mitral and tricuspid repair with the PASCAL Repair System platform. And here you see the agenda we want to go through with you today. So after my introduction, Professor Peter Lüdike from Essen in Germany will introduce to us the PASCAL Repair System. In a second talk, Professor von Bardeleben from Mainz, Germany, will show us a recorded PASCAL case on mitral insufficiency treatment. And in the next part then, Professor Rudolph from Bad Oeynhausen, Germany, and myself will present you the PASCAL Repair platform in action, showing you one mitral case and one tricuspid case. Between the cases and the presentations, as you see here in the agenda, there will be enough room for you to address questions to us, and you're invited to use the online chat platform to address the questions to the speakers. Edwards is now focusing on novel devices that address different pathologies on AV valves. It was started with a cardioband at around 215 that addresses mainly the annulus pathology, both on the mitral and the tricuspid position. Then in 2019, the PASCAL Repair System was started first for the mitral valve, and in 2020 it went to the tricuspid valve. And at the same time, a modification of the PASCAL system was introduced in 2020 for leaflet repair. And in the following years, I think we will see data with robust Edwards studies on a complete valve replacement, both in the mitral as well as in the tricuspid position. With this, I would like to end and hand over to Professor Lüdike and his talk.
So first of all, I want to thank you for the invitation and the opportunity to participate in this session. These are my conflicts of interest to declare. And I will start with explaining the key features of the PASCAL technology. We'll then go over to review latest data, and we'll then give a short look out on upcoming clinical trials. Although it might be a kind of a simplification, there are three prominent features of this new device that are pretty relevant when treating mitral and tricuspid pathologies. The supposed most prominent feature or dominant feature, because it's the biggest thing in the device, is the central nidinal spacer that is designed to fill the insufficiency gap between the leaflets and thus prevents backwards flow of blood to the atrium, as you can see in this 3D view after a successful implantation. Besides this obvious effect of filling a gap, the nitinol spacer and the broad conjugate petals contribute also to a not less important mode of action. This is reducing stress on the leaflet. And as you can see in this digital animation of a mitral valve with an edge-to-edge device with and without a spacer, the green areas display areas of high mechanical stress. And what you can easily identify is the fact that the spacer-containing device puts less stress on the leaflets since they are not pulled all the way together, but only to the level of the nitinol spacer. And if this translates into a more pronounced longevity of the results due to reducing or restoring forces must be surely answered in the future from clinical trials. But a second answer that should be given in this animation is the effect of this supposedly big device on the residual diastolic valve opening area. And as you can see as well in this animation is that the valve opening area is expected to be even larger when using a spacer containing device compared to a conventional edge-to-edge device. So as I mentioned at the beginning, it's certainly an oversimplification to regard the central nitinol spacer as a single feature, but it should be regarded more as a bundle of features to improve the effectiveness and longevity of the results. The PASCAL Ace is the future development with a more narrow profile and a flatter spacer that was designed to complement the portfolio, and the first experiences with the second available edge-to-spacer device show that it's a real improvement to have this additional size available. You see here the narrow profile. This is 6 millimeters compared to 10 millimeters in the PASCAL 10 device, and here the flatter size from the side. Especially in pathologies with interfering chordae, it seems to be an advantage to have this flat and narrow profile, especially in very medial or lateral pathologies. The second aspect I want to focus on is the design and the quality of the clasp and the retention features. Well, you can move them independently from each other, but this is nothing unique anymore and available in other technologies as well. But what is unique in the field, and we might discuss on this later during the cases, is the fact that the retention elements are aligned parallel to the direction of the collagen fibers of the mitral valve and thus minimize the force we put on the tissue. Since we have only 1.5 years experience, we still need data on this, but this technique aspects should translate into minimal leaflet laceration, and our institution, we are quite more offensive with multiple grasping attempts, as we don't see any perforation until now. The third aspect I want to highlight is the mechanism that allows you to retrieve the PASCAL once you have entered the ventricle, which is illustrated in this short movie here. And since you can easily elongate the whole device and thus create a more or less straight profile, you are not at risk to entangle with the subvalvular chordae, what is especially of interest when you work on the tricuspid side, where this can be a distinct problem, but what is also a game changer, not only in the tricuspid valve, but also in very medial or lateral pathologies. The last slide on the technical features shows the implant catheter system that consists of 3 independent parts and allows you to navigate also in 3 independent planes, and the cerebral catheter contains a side port for continuous measurement of the left atrial pressure. So these are the technical aspects that make the difference to existing technologies, and the next slides will summarize first clinical evidence from clinical trials, and I will start with showing you the efficacy and safety data from the CLASP trial, which was a multi-center, multinational prospective trial enrolling patients with severe MR who were judged to be candidates for transcatheter mitral valve repair. These are the 6-month outcome data from the whole cohort, and you can see that reduction of MR to a level of 0 or 1 plus was able in nearly 3/4 of all the patients, and a reduction to a mild or moderate MR was possible in nearly the whole cohort. And there was an impressive low 30-day mortality and not less impressive successful implantation rate when you have in mind that all the participating centers in this first study had just little experience with this new technology. The efficacy data of those patients where 1-year follow-up is available show an even more impressive result, as 82% exhibit a consistent MR reduction to 0 or 1 plus, and 100% of these patients showed an MR reduction to a level of mild or moderate or even lower. Our own first experience to confirm these early results in a multi-center study from Roman Pfister from Köln that will be published in a few weeks and was already presented at this year's TCT will show this as well. The difference when considering our single center experience is the fact that these are non-selected cases and that all patients who were suitable for transcatheter mitral valve repair were treated with the PASCAL device unless the patient explicitly insisted to favor a traditional edge-to-edge repair after thorough information about the different technologies at our center. We see a very impressive short-term or discharge result with a very convincing 30-day mortality of 0. We were facing no intraprocedural complications. There was one single air embolism into the right coronary artery, but without deterioration of the patient. There were only 2 cases of Carpentier 3A anatomies where we couldn't implant the device due to an increased mean pressure gradient above 6 mm mercury. These are very preliminary results, and we aim to learn from our One for All trial how to judge the anatomy to better predict procedure outcomes with the PASCAL device. When we look on the tricuspid side, we also have first experiences from a compassionate use series showing also a convincing early efficacy profile with a reduction of tricuspid regurgitation in more than 80% of the cases to a level of TR2 or even lower, what was paralleled by a favorable right ventricular remodeling process in this study. As you can see here, the procedural success was a little bit lower compared to the mitral side, but the safety profile was again excellent, and it will be interesting to see how these success rates improve with increasing experience and especially with the availability of the PASCAL Ace system in the tricuspid side. So this is where we are, and I give you a short lookout of what is upcoming. As you already heard at the beginning, there is more evidence upcoming, and I will focus on the MyClasp registry study, which is a post-market study that diligently collects patients and will provide high-quality follow-up data of real-world patients. The CLASP 2D2F trial aims to prove the non-inferiority of the PASCAL device compared to the mitral clip technology in DMR and FMR patients, and all the FMR patients will be judged to be on optimal medical therapy by a heart failure specialist, so that these results will be comparable to the COAPT data. And the TriClasp registry and the CLASP 2 TR study will bring up the evidence we need for interventional tricuspid repair using the PASCAL platform on the right side of the heart. I hope I was able to give you a comprehensive overview about this fast-growing technology, and I'm looking forward to a really exciting session. Once again, thank you much for the invitation, and I'm happy to answer some questions in the discussion. Thank you.
Yeah, thank you very much, Professor Lüdike, for this clear presentation and introduction of the PASCAL system. I might want to start with the first question to you. Could you allude again on your speculations on the function of the spacer? I think most of us would think the spacer should reduce the MR within the PASCAL system, but you showed, I think, some intriguing data that there might be something different or a different function to the spacer. Could you explain that to us again?
Especially the role of the spacer, that we don't need to pull the leaflets all the way together, and thus don't put so much stress on the annulus. And I think the restoring forces we have in the established technology might be an explanation why we see after 3 months or 6 months a recovery of the regurgitation, and this might be an explanation why the first results we see show very long-lasting results in MR reduction. And I think this might be a consequence of less stress on the leaflet, less stress on the annulus. But this is, I think, at the current time point, speculative. But might be an explanation.
Mm-hmm. Thanks. So, and when you now translate that to the PASCAL Ace system with a smaller spacer, what would you expect? Would it be a good indication to use it more on the mitral side or more on the tricuspid side?
To be honest, again, I think it's quite early to answer such a question, but our first experience favor it when you have entangled problems with subvalvular chordae, because it's an excellent tool when you have interfering chordae, and you can place it exactly where you want to go. And so I think the strength is on the tricuspid side and on medial and lateral pathology.
So let me then finish with one question you might want to address personally. What will be the most important study for us comparing the two systems, and what do you expect? What will the outcome show regarding class 2D or 2F? Just your personal opinion. I think it's again a difficult question, but we are curious about your opinion.
When I understand the technology right, then I would expect a long-lasting result in the 2F arm of the class 2D study, 2F study, but this is speculative.
Okay, so thank you very much for addressing all these questions. I didn't see any questions from the chat, so we will move on with our session. And now we will see a recorded case from Professor Bardeleben from Mainz, and he will show the PASCAL Ace in action in mitral position.
Thank you, Dr. Rottbauer, for the kind introduction. And I would like to move on to the PASCAL Ace system as an implant system for MR treatment. My name is Stephan von Bardeleben. I'm the head of the Heart Valve Center in Mainz, Germany, University of Medicine, Mainz. These are my disclosures. I would like to present you a case of a 77-year-old female that is presenting with signs of congestive heart failure. She's in New York Heart Association class 3. She has secondary MR, typically following a myocardial infarction in 2017. Her ROA is between 0.25 and 0.35. Regurgitant volume is about 30 milliliters. She has a small anatomy. Her LV EDV is only 128 millimeters or cc, and her ejection fraction is around 38%. So the regurgitant fraction, though, in a small anatomy is high. It's above 50%. And we would like to see how we can treat these very small anatomies now. So her clinical background is an ischemic cardiomyopathy. She has postcapillary pulmonary hypertension, but with an MPAP of only 28 millimeters mercury. Her wedge pressure is in the postcapillary field with a wedge pressure of 19 millimeters mercury. Very typical for this elderly female patient group. She is in permanent atrial fibrillation, and she has severe secondary tricuspid regurgitation, as well as chronic renal impairment, which is true in approximately 50% of the patient. So we see she's slightly anemic with 10.1 gram per deciliter. Here we see already the anatomy. We see a tethered posterior leaflet. We see a very small intercommissural diameter, which is only about 3 centimeters. And we can also see that the effective posterior leaflet is very short. This is also appreciated here in a true view demonstration of the valve system. And you can see that we have a curtain-like regurgitation of the small anatomy that is coming from the posterior part, starting at the end of segment 1, going through all of segment 2, and starting in segment 3. Here you see a typical transeptal puncture for this new device, which is and here the introduction of the eye system and the situation, the control above the mitral valve. We like very much this view. where we can test the different motions of the sheath, actually moving it anterior, as you see here, posterior. So this gives us the typical control. Note the flush port that you see between my two hands here at the 5 o'clock position. Now the system is being closed from an elongated position into a closed position, which shortens actually the length and makes it more maneuverable in the left atrium, especially in small anatomies. We take a short look here at the LA pressure. You see a discrete V wave in this patient, and as with the wedge pressure, very nicely reproduced also 19 millimeter mean LA pressure. We then continue with the case. You can now see the steering down over the aorta, down to the mitral valve. We slightly move posterior. It's a very controlled steering possibility, as you can see here. And we're simply flexing the secondary control, which is the steering catheter. And this gives us a nice movement down to the valve. We can also see that we have a fin. So this is done here on the sheath and secondarily here on the steering catheter, as you can see now with the fin in a 2 to 3 o'clock position. We nicely appreciate the device, which still has to be rotated. We have the aorta down here at about 6 o'clock, and we rotate the system now a little bit. This is done by the second operator, where you see only parts of his hand, and we rotate the system into position. We then select, like the surgeon, a neutral position where we have in a horizontal line to the two trigones of the mitral valve. You can easily see that we only see the arms, mostly here in the AP situation, not in the intercommissural situation. And now with the right hand, the second operator turns the clip slowly clockwise to get to his final position. You can nicely see that we're aiming into the sinus of the non-coronary cusp here, which is the middle of the mitral valve, a very small anatomy. And I would like to remind you that the width of the Ace system here is smaller than the P10 classic PASCAL system. We're now elevating the two clasps, which you can nicely see both in fluoroscopy, but even nicer in three-dimensional echocardiography. And you see, we don't have to change a lot, any position, neither of the fluoroscopy nor of the TOE probe. This can all be nicely controlled during the procedure. Now we lift the pin and we independently engage the clasps. So we're able to actually get the leaflets independently into the device. The device is now being closed after successful testing, and we now will arrive at a check the path situation where we try to pinpoint to the apex, true apex of the left ventricle in order to get a very perpendicular plane to the mitral annulus. So we're becoming slightly more posterior. We're checking the movement back and forth. We're still in the atrium, and you see that all those are fine adjustments, slightly clockwise with the device, as we do it here, small advancement. And we try to be, for this specific ischemic situations, in the middle of the two papillary muscles. Now the closed system with the correct rotation is between the anterior and the posterior leaflet. It is above the papillary muscle heads, as you can see, and it's nicely moving with the interior leaflet. So we're not causing any additional regurgitation at this moment. The system is totally free. It's in the largest caudal-free area of the valve. And now just below the leaflets, we're opening the clip again in the ventricle. You can nicely see that even this clip length already touches both the posterior and the septal wall, the anteroseptal wall. So it is very nice to have here something for a very small anatomy. Now we're getting below the posterior leaflet, which was heavily tethered, as you know, and it is important to engage it with a slight V shape, which we're doing now. You can already see that the anterior leaflet is on. By opening the device directly below the leaflets, we try not to engage into chordal structures that can be cross-connected. So this is a very, very safe method. We have all the time in the world, and we're now adjusting the system to be central and to be correctly rotationally aligned. You see this very nicely. On the left image in echo, you see the two papillary muscle heads below the valve in the ventricle. They pop up as bright white little spots. And this tells me that I'm very symmetrical in the valve. Now the clasps were put down, and you see that the clasp is almost reaching the hinge point of the posterior leaflet. The system is being closed, as you see, with a black knob slowly. We have all the time in the world, and we can cross-check the situation. A very controlled, very pure implant. And you see that we have enough space left and right in the intercommissural view, which you find on the left-hand side, for inflow into the valve. That's very important. I would also like to highlight that we have material which is nitinol, so which will accept some pulling pressure, but may open or be dynamic in its motion. Here you can see already with the small anatomy a very nice result. You can see that the vena contracta is very small. It's only 2 millimeters left, so it's a trace finding next to the system. And we see that even in this only 3 centimeter intercommissural distance in diameter, we achieve a mean gradient of only 4 millimeters mercury. Here in 3D, you see that we really only have a trace finding. We have a nice pulling situation, a nice tissue bridge of the leaflets from the interior side to the posterior side. We check this again in biplane imaging, and I think we can be quite happy. What is very important to know with the device, as with the classical devices, that we have even here a small spacer, and that the result typically after release will not become worse, but even better. And we'll see this in the follow-up images. Here we're checking the pulmonary vein flow, something which has been highlighted in recent publications to be of high prognostic value. So a very important step to do even with a TOE imaging. Now we're about to release the system, as you can see by the unscrewing of the blue knob here. You can see that the system opens and we have a very stable situation of the PASCAL, which is now being connected to the posterior and anterior leaflet. And this stability of fluoroscopy is also a highlight, which demonstrates a very good tissue bridge, a very good situation. So you see the opening here in the P1 and the P3 segment. We see this trace residual regurgitation that has taken away the confluent curtain-like shape of an ischemic mitral regurgitation. And we will be interested to see how this result is being maintained across a discharge of 1 month. And here I would like to share with you the additional information that we have from the follow-up situation. This is 1 month post-procedure, and you can nicely see that the gradient after release is less. So gradient in real life is only 1 millimeter mercury in a very small female anatomy that you've seen. The max gradient is 3, and you see that the Doppler intensity in the inflow is more than the backflow, which leads to a trace or mild result. On the right-hand side, you see under normal hemodynamic situations in 4-chamber view, on the left lower in an apical 3-chamber view, and in intercommissural view, where you nicely see the opening of the valve and the 2 chordal areas of the medial and lateral papillary muscle, you can nicely see that there's only trace regurgitation left after 1 month. So a very effective first-class procedure in a formally prohibitive small anatomy. And I think the patient was doing very, very well. What is also important is that the case you have seen was the second case in Europe or worldwide with the PASCAL Ace system. And it was actually the first case ever for the PASCAL Ace system for Felix Kreidel, who was first operator in this case, standing next to me here on this slide. So you see that there was, with a high volume center, no experience level increase needed. It was a first class implantation, no learning curve. and an exceptional good result with this device. So I thank you very much, and I'm looking forward to your questions.
So terrific case and terrific overview. And you said it was the second Ace case ever done.
Yeah.
So could you explain to us why did you choose in this specific case the PASCAL Ace system and not the already established PASCAL system? What would make you go that way?
Well, one of the reasons is the width of the system. So we, of course, calculate always the intercommissional width. And here we had an annulus width of 3 centimeters. Going down to a PASCAL P10, this would have been prohibitive and actually excluded in the class 1 and class 2 trials because we had a valve orifice of about 3 centimeters, which would have been out of range for the studies. So this system is about 4 millimeters smaller in width. It has also a smaller spacer, so it's not a 4 to 5 millimeter spacer, but a very small 2 millimeter spacer in width that is very effective in these small anatomies. And also the shape of the paddles has been changed. While the PASCAL P10 is a little bit bug-shaped, it's round, so it was designed primarily to be very atraumatic to the leaflets. This system is a little bit more edgy and smaller, so it penetrates better between the cords. This was something we have seen in the first case. We did 5 cases in a row. And actually, I already on the second case, I gave the first operatorship to Felix, and I said, well, this is your first one, just do it. And we recorded all 5, and the result was first grasp. It was spectacular, and I said, well, we take this for life in the box case.
Okay, so sounds great. Could you give us an opinion on the learning curve of the system? So many centers are already familiar with the mitral clip system. So if you would start up a PASCAL system, what are the 3 major things you should be considering before you give the whole case to the second operator, as you said?
Yeah, very nice. I think the learning curve is extremely fast, and all 4 of us have experienced this. And I think even with the Ace system, it will be faster because it's more similar to any edge-to-edge therapy that we have worldwide at the moment. So to give you an idea, the possibility to really put leaflets on the device here is relatively simple. The only thing that you have to be aware of is that you're working with an unkeyed system instead of a keyed system. So you have to make sure a little bit that you're not turning you at 3 different catheters, which are independent to each other while the implant. So what we introduced in Mainz very nicely was a rotational control by fluoroscopy. So you've seen that I arranged the C-arm exactly to the echo position of the device. And beginning from this situation, I only control the rotation in fluoroscopy, not in echo anymore. And this is very, very efficient. The second thing that we try to do is we try to engage the leaflets deep into the device. I think that's also a very important learning curve. You've seen the posterior leaflet. The frictional elements were engaged almost at the hinge point, at the annulus of the system, which is highly effective. And the leaflet length is needed to seal against the spacer. So a very important step, especially in the PASCAL system. And the last thing I would like to highlight would be that you have now a mobile clip system. So this is nitinol. I shortly alluded into that in the presentation of the Life in the Box case. So if this system comes under extreme stress, and this is possible at the annulus because the annulus is contractile, it will open a little bit. And this is unique in the market. So if you have MAC or if you have a very close proximity to the annulus, I would prefer this system on these 2 issues, definitely.
Okay, thank you very much for these clear answers, and then we will move on to further cases, and the next case will be presented by Volker Rudolph from Bad Oeynhausen.
All right, so thank you very much. I'm very happy to be part of this great session. I'm excited to share a case with the PASCAL platform with you. These are my disclosures. And the case is a 78-year-old female patient who suffers from progressive dyspnea, which started in April 2020. The procedure I will show you was done at the end of August. She already had in her history coronary 3-vessel disease, underwent CABG in 2009, where all her venous grafts were occluded, but native vessels were revascularized in 2019. So she had a stable situation there. Her left ventricular ejection fraction was mildly impaired with 45%. She had a history of strokes, actually multiple strokes. Her last stroke occurred in 2000, and she had some considerable neurological residuary there, and also persisting atrial fibrillation. Her Euroscore was 3.8, and because of the neurological situation that we mentioned, I mean, she was mobile, but she was impaired with a hemiparesis. Our heart team decided to go for interventional therapy in her case, and I will now show you the cardiac situation. This was her screening TTE. As you can see on the left side, the mildly impaired left ventricular ejection fraction with a hypokinesia in the anterolateral wall, which was also probably responsible for the functional MR that you can see on the right side, which I think without doubt is a severe mitral regurgitation. These images are from her baseline TOE, and you can appreciate that this is a central functional mitral regurgitation in the left upper panel in this biplane view that is shown, and this is also reflected in the 3D images in the lower panel, where you can see in the image without color that there's a slight pronunciation of the coaptation deficit lateral towards the lateral side of P2, but obviously the mitral regurgitation is restricted to the P2A2 area. The opening area or the orifice area of the valve was 4.2 square centimeters, as you can see on the right upper panel. So it was okay, but it was slightly on the low side. Nevertheless, our strategy was to choose to go for one device actually, and we choose the P10 device, and you can see our first grasping attempt here, where I think you can very nicely see that both leaflets are nicely loaded on the clasps. However, this resulted into residual mitral regurgitation chat, which after some discussion we considered as too large to leave it as this, and even after we did one attempt where we tried to optimize the grasp, but I mean you see that this grasping attempt was rather well, so we could not really optimize anything with this one device, and we have a predominant residual chat lateral to the device that had been implanted. So we of course looked for the gradient, which was 2.7 millimeters of mercury, and so based on this assessment, we decided to choose a second device. And because, as I said, we started already with the 4.2 square centimeters of orifice area, in this situation we took benefit of the new PASCAL Ace device, which, as you have heard, is a smaller device, which as opposed to the P10 device has only 5 millimeters of width. And the grasping of this device you can see in this image. Again, it was not very difficult to get the leaflets, and with this second device, we now had a very good reduction, virtually elimination of mitral regurgitation, with a mean gradient of now 2.2 millimeters of mercury, so numerically less, but of course you can see that the curve or the velocity curve has a much slower deceleration time, now indicating that, of course, now the orifice area was more restricted, and we did an analysis on this, and indeed we found that the residual orifice area in the reconstructed 3D analysis was around 1.4, 1.5 square centimeters, but nevertheless decided to leave this based on the gradient and based on the fact that this would of course be probably sufficient, and this we could corroborate in the discharge echo. Here you can see that on the discharge CTE, which I think is very important to perform in such a case, of course, and to show here, there's no residual MR, so elimination of MR. This is in the still inlay, the situation before the intervention, and the gradient in the TTE was then mean gradient was 4 millimeters of mercury. So I was asked to propose a decision tree for device selection, and I know this can be, and I hope we will discuss this after this talk. The way we do this is we start with the lesion location, and if we have a commissural location of our lesion, I think our preferred choice is the Ace device, because it's of course it's smaller, and thus it's easier to handle and to steer in regions where you have chordae as a problem. Whereas if there's a central lesion location, the first thing we do is we look for the mitral valve orifice area. And if this is very small, and I think it's very clear that we will go for a small device. If at all, this is then a morphology where edge-to-edge repair is feasible. If, on the other hand, it's a larger valve, larger than 4 square centimeters, we would primarily consider a P10 device. If it's in between, I think what we do is we look at the width of the bicommissural vena contracta, or just at the severity of mitral regurgitation. So if you have a larger chat in this situation, I think you could still tend to go for P10. If it's smaller, then yeah, and this obviously, I mean, if you have a situation where it's a degenerative MR, you could also look for the flail gap or the prolapse that you have. And yeah, well, once we implanted one device, we will just start over this decision tree again with the second device if the need arises. So in aggregate, I think the addition of this PASCAL Ace device really gives us more versatility in these procedures, and we all know that this is much needed. And so this is the end of my talk. I thank you for your attention, and I'm looking forward to the discussion.
I'm back, and you just saw a beautiful case presented by Professor Rudolph on the mitral position with an excellent result. And I will now move to the tricuspid valve. And there are no significant disclosures to make from my side. So I quickly step to this slide. And as you see here, I think in comparison to the mitral valve, you have certain challenges on a tricuspid valve. And there are two important points. When you look at the valve, usually tricuspid regurg goes along with a severe annulus dilation. And this ends up for you then in the malcoaptation of the leaflets. And it also goes along with right ventricular dilation. So you see much more tethering, especially on a septal leaflet in tricuspid disease. And then there might be the anatomical challenge that you have a pre-existing device lead going across the tricuspid valve. And regarding these anatomical challenges, you also have imaging challenges, and everybody who's done on tricuspid cases knows about that. So you are quite happy if you have adequate visibility of all valve components while planning your procedure, then you are good off and have a chance of getting a good result. But leaflet insertion is much harder to visualize while doing a tricuspid case. And if you have other cardiac implants, for instance, aortic valves or atrial septal devices in place, this strongly interferes with shadowing with your images while doing a tricuspid case. So now let's move to our case, and you saw that in the former presentations. So we have now the choice to either go on the tricuspid position with the PASCAL device or with the PASCAL Ace device. And there are certain considerations to make, and this was already pointed out. The PASCAL Ace has a much narrower profile. And this gives us, and at least in the Ulm experience, much better imaging while grasping the leaflets. And there is also discussion going on if you get with a smaller device even a stronger effect on annulus reduction or with a bigger spacer, and the data has to come up to address that for all of us. The second important thing is, and this is an especially very, very important feature that was introduced by the PASCAL system, is the independent grasping of the leaflets. You really need that while doing good tricuspid cases, and then this should influence your choice of treatment. And the third thing you should consider is the flexibility, the nitinol flexibility of the device. This also, and we saw that in the first talk, puts much less stress on the leaflets. And I think this is an important point at the very end of the procedure, where we know that volume changes in the patient might have a very dramatic effect on the annulus itself. So let's go to the case now. It's a 70-year-old female which was hospitalized for repeated right heart decompensation, so a classical case of severe tricuspid regurgitation, and she had no left heart disease. And the challenge in this case was that there was already a pacemaker lead going across the tricuspid valve in this patient. And here you see the pre-procedural transesophageal echo. Here on the left screen, you see the pacemaker lead crossing over the tricuspid valve. And on the right side, you see severe tricuspid regurgitation. Now this is our first intraprocedural echo, and this is the so-called transgastric short axis view. And here you see marked with the S, the septal leaflet part, and then the anterior leaflet part and the posterior leaflet part. And on the right side, the color echo gives you an impression of the severeness of the tricuspid regurg in this patient. And now the image is stopped, and on the left part, there is the orifice area, or the gap is highlighted, and this is a rather huge gap in this patient, and this is why you need independent grasping to treat this type of valve. So what you always should do is you should consider, and I think this was already pointed out by Volker Rudolph, what is your strategy when you have the images? And you see here on the left side two red arrows, and they are following a line that goes from the antero leaflet towards the septal leaflet. And on the other side, there goes a line going from the posterior leaflet to the septal leaflet. So we are planning on doing two PASCAL systems in this patient. And while we're doing two, we focused on the ACE system. Now we are in the procedure, and you see here, usually you start, because of imaging quality, on the septal part, and you see here the PASCAL Ace system nicely placed on the left side, and on the right, everything seems to be fine. we grabbed the septal and the anterior leaflet, but we are not very much at the center of the coaptation gap. So we weren't very happy with that grasp, although we had both leaflets quite nicely in. So we replaced the whole ACE system. We now moved it, you see that on the left side, much more centrally, and we turned it clockwise. And then we get, again, first contact to the anterior leaflet, and I'll show you that on the next movie. So we have already here on the right image on the lower side, the anterior leaflet is already within the PASCAL system trapped. And then we move the whole system, and this is a big advantage now. We move the whole flexible system towards the septal part of the tricuspid valve, and we are already touching here the septum, and then we put the glass down on the septal side, and then get, when we are happy, a good result. And this was the case here. You see now the first PASCAL Ace in place here on the anteroseptal part, and then we moved on, and we took the second clip, and you see that is turned a little bit towards 10 o'clock, showing from septal to the lateral wall and to the posterior part of the leaflet. And then we close it here, and this was an easier grasp on both leaflets. And I think with that, we achieved a very, very nice result. And I think this is what we expected. So we had no remaining TR, and we had this constant result. Although the pacemaker lead, and you can see that in the left part of the movie, still is in between the two PASCAL Ace devices. So with this, I want to summarize this case for you. So the PASCAL Ace implant system allows well-controlled treatment of severe tricuspid regurg, even in complex situations, such as crossing pacemaker leads. I think that's very encouraging. The PASCAL Ace implant leads to reduced imaging artifacts. This is our experience in regard to the PASCAL system. The independent grasping is very helpful in the percutaneous treatment of TR, and I think you should use that to have a very well-controlled grasping and no injury of the leaflets while doing your procedure. And the flexibility of the PASCAL system might lead to less leaflet detachment. There is no data out yet, but it could potentially be the case, especially on the tricuspid valve, where volume effects on the valve annulus can be quite severe, and stretch on the valves had to be reduced. Okay, I think we are live, and it's horrible to see its own case pre-recorded. So
it's not spectacular, so it's not that difficult to enter the discussion, Wolfgang.
Okay, yeah. But let's get started. I think Volker had the challenge to show his decision tree on the ACE or the PASCAL system. So let's get started with Peter Lüdike. What do you think? Would you go the same along the same lines, or would you do something different in the tree, and why?
No, I completely agree with this decision-making process from the colleagues of Bad Oeynhausen, because I think this is very clear, and this covers the experience we made, especially when regarding the valve size, like we saw in the case from Mainz. I guess the biggest challenge for all of us is to choose between the technologies. But I think the proposed algorithm is excellent.
Ralph, you agree on that?
Well, I do agree, especially on the issue of the ACE selection. For the P10, I would add actually that the A2, P2 position is an ideal space for this device. So irrespective of the size, if we go into commissural or some areas where we want to prepare a more approximation of the leaflets or of the annulus, as you've nicely shown this actually in your tricuspid case, I would also put, even in larger anatomies, the ACE into perspective, and I would not exclude it simply because we have a larger valve. I think that's a very important message. So what we use the ACE for is also to prepare in a very large anatomy with a gap, to prepare this gap, that the gap gets smaller, and you do an ACE first, and then you put a larger spacer in the severely tethered area. And I think this implant technique is also very, very helpful to get extremely good results. And there I wouldn't put two P10. I would always combine a P10 with an ACE, for instance. So I think the whole situation is even more complex. But to start with, I think Volker's scheme is extremely helpful to pre-select the devices. But I would encourage you to have more anatomic and some sub-chapters to this book. So this is only the title for me. And I think we could open a little bit more pages to it in the future.
Yes.
Volker, would you like to comment on that?
Yeah, sure. I mean, I could not agree more. It's really the great thing we have now after 10 years or so, where we had one device and had to come along with it, that we have so many choices now. And I mean, we all know how different morphologies of the mitral valve can be, and tricuspid too. That, I mean, it's just great to have all these opportunities now, and I think it's absolutely necessary to play with it during the procedure, and it's great to be able to do this. But certainly, on the other hand, I think if you go into a procedure, you should have a plan what you do, and for that, maybe such a decision tree is something that helps you or so. But I mean, it's completely arbitrary, of course. I mean, there are no data on it, but yeah.
So Volker, two questions. Is it difficult to put two PASCAL systems together next to each other? Is the alignment a little bit easier with the mitral clip system? What do you think? And would there also be the case where you would combine a mitral clip and a PASCAL system, or do you think we don't need that?
Yeah. So, I mean, with regards to the first question, I don't think it's difficult. What we do is always we go in there in the elongated position, which makes it very easy then to position the second device. And well, the second question is a question that I have to handle with my business director. So in one procedure, no way to do it. But of course, I mean, if there would be a recurrent MR, yeah, I mean, certainly you could combine it in any way you want.
We just have to redistribute some money from Ulm to the other centers. That's all.
Okay. Yeah. We have the highest church, but not the most money. Okay. So I think we are at close to the end, and I will thank the speakers for the excellent presentations and the cases and the discussion. And I want to thank to Edwards for sponsoring that meeting and bringing up this beautiful PASCAL system that gives us novel options to do edge-to-edge repair on AV valves and with specific features like independent grasping, flexibility, and different spaces. And with this, I want to conclude and say goodbye to everybody.
Goodbye.
Bye-bye.